virus affects the respiratory tract and can cause serious complications, even death, especially in people at risk. Someone who's infected can present various symptoms, including fever, a new or worsening cough, difficulty breathing, or a sudden loss of taste or smell. Even if they show no signs of illness, an infected person can be contagious and spread the virus to others. COVID-19 is transmitted mainly through contact with contaminated droplets. When an infected person speaks, coughs, or sneezes, these droplets can travel a distance of up to 2 meters and infect people nearby, or land on objects or surfaces where the virus can survive anywhere from a few hours to a few days. Someone who's infected can also contaminate objects and surfaces by handling them after touching their eyes, nose, or mouth. Therefore, it's important to disinfect any object or surface that has come into contact with other people and may be contaminated. In order to prevent the spread of the virus, the number of people in private gatherings at home or at the cottage should be limited, whether you're with family or friends. And when you get together and go out, you should keep a distance of 2 meters from people who don't live at the same address as you. Cover your nose and mouth with a tissue or the crook of your arm when you cough or sneeze. Avoid touching objects and surfaces unnecessarily, and keep your hands away from your face. You must wear a mask or face covering in all public spaces where physical distancing isn't possible, such as in stores, supermarkets and restaurants, and on public transit. Lastly, wash your hands regularly with soap and warm water for at least 20 seconds. Or use an alcohol-based hand sanitizer when this option is not available. If you have COVID-19-like symptoms, stay home, avoid contact with other people, and call our information line. Together, we can help stop the virus from spreading. Let's continue to protect ourselves and others properly.
Good evening, everyone. My name is Lion Ansel Innes, President of the Lions Club of Barbados East, the club which is hosting this webinar. Welcome to the first in a series of health-related matters. And tonight, this one is very topical and should hold much interest for you. At the end, you will, I hope, we will be well educated. So I now turn you over to the moderator, my second Vice President, Lion Terrence Innes.
Thank you, Lion President, and good evening to all. First, let me apologize for the delay. We have had some technical difficulties, but we thank you for your patience. My task this evening is to moderate this event, and I'm particularly pleased to welcome our panel of eminent persons, Dr. Clive Cave, Dr. Elizabeth Ferdinand, and Ms. Marianne Redmond. Before I introduce our guest speakers, let's go again. Dr. Cave is committed to his vision of implementing incremental data-supported quality change to improve lives. He is regionally recognized as a leader in newborn services and has spearheaded successful programs in both this and other areas. Having held several key leadership and administrative positions within the QEH and the Bayview Hospital and the University of the West Indies, he is conversant with medical systems in Barbados. As an active and in some cases executive member of several arts and heritage organizations, he has a keen interest in the creative arts and in preserving Barbados' cultural legacy. Dr. Cave is currently Senior Consultant Pediatrician and Neonatologist at the Queen Elizabeth Hospital, Senior Associate Lecturer in Child Health at the University of the West Indies, Co-Coordinator of the QEH Internship Program, and a consultant with World Pediatric Project's Eastern Caribbean NATO Network. Dr. Cave is currently the Director of Medical Services at the Queen Elizabeth Hospital here in Barbados. Dr. Elizabeth Ferdinand. Dr. Ferdinand was born in Guyana, and on completion of her medical studies at the University of the West Indies at the Mona campus and her internship in London, she returned to the Caribbean and was appointed to the Queen Elizabeth Hospital in 1976. On completion of her postgraduate training in public health, she was appointed medical officer, senior medical officer, and subsequently chief medical officer of Barbados. During her years of service, she has mentored many medical students, interns, junior doctors, and healthcare professionals in the principles of primary health care. Dr. Ferdinand was instrumental in having Barbados declared polio, measles, and rubella free. She led the team in the introduction of several new vaccines to ensure that the country was free of vaccines-preventable diseases. Her work in disaster management has prepared Barbados' health sector to be responsive to any disaster. She has also assisted other Caribbean islands in the areas of immunization and disaster management. Dr. Ferdinand retired from the government service in 2014, but continues to work as a part-time lecturer at the University of the West Indies at Cave Hill. Dr. Ferdinand is now the public health specialist and co-coordinator of the national COVID-19 vaccination campaign in Barbados. Ms. Marianne Redmond is a teacher who has been in service for over 40 years, and having started in 1980, and she's still actively teaching. Ms. Redmond is currently the president of the Barbados Secondary Teachers Union. She has served as second and third vice president of C2SAB and the first vice president of the Caribbean Union of Teachers. She's currently a member of the National Advisory Commission on Education. Ms. Redmond comes to us this evening well equipped to offer an apt perspective on education and COVID. Ladies and gentlemen, we welcome our panelists and now hand over to Dr. Cave.
Thank you. Good evening, everyone. My special thanks to the Lions Club of Barbados East for this invitation and providing this opportunity to have this talk with you. We've been at COVID for a very long time, it seems, but really it's a new disease that has inspired new prevention, treatment, vaccination. As with all things new, there are many questions and some answers which are true and some not so true. So I hope during the course of this conversation, we can discuss what is known, what your hopes and fears and concerns are, and maybe debunk some of the myths around COVID vaccination in children. I guess by now everyone knows that COVID is a virus like the cold or hepatitis B or AIDS. We know about viruses and we know that they all have their individual characteristics. Some viruses like the lungs, some like the joints like chikungunya, some affect the bleeding system like dengue. Some like COVID-19 originally seemed to really like the lungs, but seems now to have developed a wider taste and liking other parts of people's bodies. Some viruses like older people, some prefer children who are more vulnerable. The COVID-19 virus, we thought at the beginning, had a predilection for the old and people with comorbidities, but now as it changes with the Delta variant, it seems as though it likes younger and younger people, and children have become more susceptible to it. All this change is something that we're accustomed to seeing in viruses. I think in the history of mankind, this coronavirus has been under the most scrutiny for the longest period of time. And in an era of social media and lots of people offering opinions as fact, selecting which facts to make an argument, it can be really very confusing. It can be confusing to professionals who are steeped in studying disease and viruses. So I can only imagine what it must be in those of us who have to get ourselves up to speed with what is current and then make a judgment as how it affects our lives. And in this case, what we're talking about tonight, just not how it affects our lives, how it affects children. So coronavirus is here. We know it is in our country. It has been here for a while. We know we got it under control in the earlier parts of this year, and then we maybe took it for granted and relaxed a little, or maybe it changed so as to better survive, which is what viruses do. It's a constant battle between the host and the virus as to who wins. And now the virus has launched a new assault on our population, including children. We do have many layers of protection against this virus. You must all be tired of hearing of sanitizing your hands. Why do we recommend that? Because viruses can live on surfaces, and in order to infect someone, they have to be transferred from that surface where they may have been recently put down by somebody coughing or sneezing, and our hands then transfer them to the vulnerable portals to our body, which are the mucous membranes, any pink lining, the eyes, the nose, the mouth, breathing in. That's what we mean by droplet infection. So droplet infection, and we can argue about how big the droplets are or how small or how many, but it only makes sense, and this is what the experimentation and real life experience has shown, that if viruses come from me in my saliva and want to get to you, let's put a barrier here. What kinds of barriers? Face masks or face shields, any kind of face covering to a greater or lesser extent will stop that virus from being transmitted from one person to another. So we wash our hands to protect ourselves from transferring it from surfaces. We wear face coverings to stop protecting it, to stop ourselves transmitting it to other people nearby. Now, the virus goes into the atmosphere, and the closer you are, the more likely you are to get droplets or more droplets. So the further you stay, the less likely that virus is to leave someone and fall to the ground and not affect you. So that's what social distance is about. We can argue about 3 feet versus 6 feet. Obviously, if you were 2 miles away, you would have absolutely no risk. And if you were right up in intimate space with someone, you would be at a higher risk. So we try and find some kind of workable distance. And I think most people are comfortable with saying that with the use of face protection and a space of about 6 feet, we have reduced our odds significantly. Now, sure, 12 feet would be better, but then we might have to shout. And in shouting, that transmits the virus more effectively. And we have learned that in the churches where people sing, discussions where people project their voices, those are at-risk situations and best to be avoided. We know that if we put the virus out into the open air, it dilutes and disseminates much more rapidly than if we do it in an artificial air-controlled environment. So the open air and outdoors would be preferable to an indoor space. And our most recent and probably most effective layer of protection, not from catching the virus, but from getting very ill with the virus, is vaccination. Now, why does this matter? A virus like the cold, which we catch, which we're inconvenienced by, very unlikely to have complications by anyone to cause serious illness and die. And it runs its course until the next virus. We're accustomed to those. Those don't really impact our lives. But if a virus has a serious effect, and this coronavirus does have serious effects in that it can make people ill and people can die, then that's something that we have to battle. We have to protect ourselves and our loved ones from this potential killer. And we know that in Barbados, we've had 50-something deaths, 52, 53, 54. They are increasing daily. Remember when we were at 47 for a long time because we were doing all the right things and the virus was at a low prevalence in our society. It's different now. And what can we do to change our odds of getting really sick? That's where this discussion on vaccination comes in. Now, why children? Why weren't children recommended to be vaccinated from the very beginning? Well, we have always known that we protect children because they have a developing immune system. So we've always looked more closely at pregnant women and children and vulnerable people. Now we know that on balance, at the beginning of this pandemic, vulnerable people, meaning the older and people with hypertension, diabetes, heart failure, some sort of coexisting condition, were most vulnerable. So with an adult developed immune system and a higher risk, it made perfect sense for those people to be vaccinated first. And then as more people were vaccinated and studies continue and world life experience was gained in many, many countries across the world, we realized that the safety profile of the vaccine was really very good and its effectiveness was also very good. So then you could decrease the age at which you would try this vaccine in studies. And once those studies were successful, then the vaccine is approved. Now, we know biologically that around the age of 12, that's when the immune system is practically mature and can be treated like an adult. No surprise there. We've known this for a long time and with our experience with other vaccines. We do know that in younger children, sometimes the dose of the vaccine has to be altered. And that's where the work has been ongoing, not because of concerns about the safety of the vaccine in children, but because we want to get the dose right. Too much would be unnecessary and maybe overwhelming. Too little would be not effective. So the work is ongoing and the indications are that it will soon be approved for younger children. But right now in Australia, places in Europe, North America, most recently the United States, the Pfizer vaccine has been approved for use in children from 12 to 18. Now, 12 to 18-year-olds may not necessarily want to regard themselves as children, so we can call them younger people, and it is absolutely safe, as best we can tell from all the experience that has been garnered from around the world, that there are minimal side effects to the vaccination of children in this age group. We also know from experience around the world, which is being corroborated with our experience here in Barbados, that younger people are getting sick and ending up in our Harrison Point isolation facility. And not just there as asymptomatic carriers, which is what we used to kind of regard children as being, but ill patients requiring care. So on balance, the disease of COVID can affect children. That is a given. They can become sick. Not maybe as many of them will become sick as adults or older people, but if something is only 1%, that 1% doesn't really matter if you are that 1%. So protection is needed for children. Otherwise, we expose them to an infection with coronavirus. They take their chances of being reasonably well, or they get ill, and they can get ill with the usual viral symptoms like a bad flu that passes, but more concerning, they may develop a multi-system kind of infection. The multi-system response in children, an inflammatory response stimulated by the coronavirus. And this can affect many, if not all, of the body systems. As they fail in degree of severity, that can progress as far as death. That is certainly a very important severe disease to be prevented. It is not very common. but it can happen, and it has happened in Barbados. We have recorded one case of a child here in Barbados who developed that syndrome. There have been other children who have had associated infections which have made their underlying diseases worse, and that too would be a concern. Now let's weigh that with the effects of the vaccine. Everybody is talking about myocarditis in teenage boys from the vaccine. Myocarditis is an infection of the heart. That occurs with viral infections. It also occurs in the coronavirus. In fact, you are much more likely, even though it's a rare condition, to have that kind of myocarditis if you get a COVID infection. If you get the vaccine, it is less likely, but possible. And what we have learned is that most of those cases, the majority, the overwhelming majority of those cases who have as part of their response to the COVID vaccine an inflammation of the heart, they are self-resolving and recover over time with fairly mild treatment, but they would need to be monitored. So as a parent or a young person, what is your decision? Take your chances with a virus that is evolving and seeming to become more virulent, affect young people more, so your chances of getting really sick go up? Or do you take a preventive route so that if you do catch the virus, you are unlikely to be that sick? If you are vaccinated, you are probably less likely to spread it, although you can. And therefore, as part of your social and civic responsibility, you are helping to protect those who may not be able to protect themselves as well. Vulnerable family members, grandparents, other children in school with you, younger siblings who cannot, who don't have the choice to be vaccinated. So that's where we are now. Coronavirus is here. We have multiple defenses, but the most recent one for us to consider and consider really seriously is vaccinating young people to protect them, but to protect us all. Thank you. I look forward to your questions.
Thank you very much, Dr. K, for that very insightful presentation. We go directly to Dr. Ferdinand, who will speak about her work with the vaccines. Dr. Ferdinand.
Sorry about that. Good evening, everyone, and thank you very much for having me on the program. Well, Dr. Cave, as usual, has given his eloquent lecture or talk, and I wonder if I have anything extra to add, but I did put together some slides, which I'd like to share with you, maybe on a different slant to what Clyde has presented. So if you would permit me, I would like to start the show. Oh, they've only got the host. Okay. Okay, can everyone see the slide? I hope, right, thank you. Okay, so as Dr. Kafer said, we know that the pandemic began in Barbados, and we tried to respond as best we could. At the time, and still is, the prevention is the only way to go. And he has expanded on what masks, the use of masks, our social distancing, and our hand hygiene. And I think we're all sick of hearing it, but we cannot afford to be sick of doing them. So again, we continue to talk about masks, social distancing, and hand hygiene. And in his talk, he explained to you why we need to do these three things. vaccines were developed eventually and came on the market. And we knew that in any disease, vaccines would take a little time to be developed. And so although the disease began in late 2019, vaccines only became available in late 2020. Our vaccination campaign could not start until vaccines were available here in Barbados. And we know that the developed countries made huge payments and pressure on the suppliers to have surplus vaccines in their country. And this left the less developed countries in need and want of vaccines. Our government made every effort to procure vaccines. They went through the usual route of where we buy our vaccines, that's the Pan American Health Organization. And we also went on the open market, and the Prime Minister, and she had a group of eminent persons working in all angles to try and procure vaccines for Barbados. We were fortunate, and I don't know how it came about, but I think it was Prime Minister to Prime Minister. India made us a gift of 100,000 doses of Covishield AstraZeneca vaccine. And with that arrival of the vaccines, we began to make plans. Well, we had started already a little bit to make some plans on how we were going to deliver our campaign to Barbados. So from the inception, there had been many, since the inception of the campaign, there's been many changes. Initially, we started administering them from clinics, also with the use of outdoor drive-thrus and a few selected schools. But after the first use of schools, we found that the school began face-to-face, so we had to leave the schools. Then we had the ashfall, and we could not go to our outdoor sites like the drive-through at the Globe Drive-In or the drive-through at the university. So we had to look for indoor locations, which, as Dr. Kaver said, could be dangerous because it's the same air in the indoor, but we had to look for indoor sites. And so we were fortunate in getting some hotels, because they were empty at the time, and they gave us use of their facilities, like their halls at Sandals and the Crane, and the Masonic Lodge at Salters in St. George, Seventh-day Adventist Church at Mile and a Quarter, the Art Gallery at Queen's College, at Queen's Park, and a building called Number 2 Building in Harbour Road from the BIDC. So we mainly discontinued the clinics because of the interruption of the clinic functions, because we know that clinic functions are important, as well as the need for vaccines are important. So we had to do a balancing act. We were fortunate in having some private doctors who initially volunteered, and they did a mobile service to give at least the first doses and then the second doses to some of the shut-in people that we had. Currently now, things are evolving every day. I tell you, every day is a new thing. So there's nothing cast in stone, and we just, moving forward. We have 9 sites that are being used, but expanded to mainly schools because of the fact that when we got the Pfizer and we got a gift of Pfizer, let me go back by saying we had only AstraZeneca for quite a while. And then we were given 30,000 doses from the government of China, and that vaccine is called Sinopharm. And then more recently, we've got 70,000 doses of Pfizer from the USA. So those are the 3 vaccines that we are using now. Now, the only vaccine that is available or approved for use in children between 12 and under 18 is the Pfizer vaccine, okay? So we wanted to get the children vaccinated as quickly as possible before school began in September this month. And we did start with the use of the schools to deliver the vaccines, hoping that parents would bring up their children. And those parents who were not vaccinated, we would also give it to them, as well as the child or children, as the case may be. We then got a mobile bus, and that was introduced for shut-ins. And Sagicor gave us another bus. So now we have 2 buses that are doing community work. At the beginning and gradually into the middle, all the health institutions like the hospital, psyche and geriatric, the private nursing homes were all visited, and their staff and the patients were offered the vaccine. We have also done the prisons and large institutions. We've got hotels and supermarkets and more larger businesses to send their clients or staff to certain sites, or we sometimes go there to deliver the vaccine. Now, as of today, no, don't look at this last note, please. Don't look at that note. We have administered 122,902 first vaccines, of which 52,305 were men or males, and females 70,615. So you can see we have roughly 20,000 more females had their first dose than males. With our second doses, we have delivered 96,689. And we see these figures usually on the dashboard at night. They're a little behind because they're the day before. And again, we see 40,331 males and 56,358 females. So more females are coming up for their vaccines. Now, the importance of the second doses is that they then become what we call fully vaccinated. And that's where we should all strive to be, to have at least 2 doses and be fully vaccinated. Our next slide shows the doses by vaccine. Sorry, this is not correct. Okay, by the type of vaccine. And you see that we had AstraZeneca for quite a long time. And we've used 100,166 AstraZenecas versus the 18,190 Pfizer and 4,816 Sinopharms. When we look at the doses, and I haven't brought the adult people because we're focusing mainly tonight on children. And we see that children between the ages of 12 to 14 years, we've done a total of 3,012, of which we have, and the roles are a little reversed in this case, where we have 1,530 boys and 1,482 girls. In the age groups 15 to 18, just under 18, we have 1,364 males and 1,590 females. So we can see, and you teachers among us and Ms. Redmond would realize that 3,000 children are a drop in the bucket of those that are eligible to have the vaccine. And at this point, and we'll probably talk about it as we go into the questions and answers, but we need to encourage our parents and guardians to bring their teenagers up to get their vaccine. This is the only vaccine that they can have and we're strongly recommended that parents do bring them up. If we go on a little bit, this is just a chart to show the parishes and how the distribution is. Of course, the larger parishes like St. Michael, this is St. Michael and Christ Church, and so they show a heavy uptake. But the small ones like St. Joseph, St. John, St. Andrew, I think this is St. Thomas here, you realize that they have not taken up the vaccines as much. Yes, they have a smaller population, and we need to delve down and drill down a bit more as to why they haven't. But that's just to give you a pie diagram look at what's happening around the country. Now, of course, with any vaccine introduction or new medicine or drugs or procedure that is introduced, one has to usually have challenges. And we know that over the period of time, I will mention a few of those challenges that we've had. I told you we had a shortage of vaccine and the types of vaccine we've had, and juggling with expiry dates, because vaccines are medicines. And like even with our food, we have expiry dates on them. And so it is with vaccines. And, you know, when you're getting something, you've got to look and make sure that the expiry dates are good and that you have to use them up before the expiry date, because after the expiry date, you have to throw them away. So we have to juggle very carefully the vaccines that come in. We had the ash fall and the whole country suffered with that. We had Hurricane Elsa and we all suffered with that one. We have staff fatigue. There's no doubt that the medical fraternity, the nurses, the paramedicals, and all the people that work in the Ministry of Health are tired and fatigued. And we really, I don't think we're seeing the light at the end of the tunnel. So we have, and we know that we have to continue. So I ask you to pray for us that we will all continue and get strength to get to the end of that tunnel. In our vaccine program, we've suffered from IT problems with our internet access, especially when we have to go off-site. We have insufficient numbers of staff. We're crying out for nurses and other staff. We have inflexible IT programs, and we have no real budget, but this is just something I think that we suffer from, but we have to go through the Ministry of Health for things. But even today, something I said, gosh, we need a few plastic bottles to squeeze the sanitizer. You know, there's not $1 around that we can run out and buy a $3 store and get some of them. So those are little things that sometimes really frustrate you, put you back. Oh, okay, I don't know what's happening. Okay. So what are we thinking about a way forward? We have to address any hesitancy factors, because we know for sure that we have a lot of adults and we have the children, a lot of children between 12 and 18 who have not presented for vaccine, and we need to know what is causing it. We have some ideas. We've seen the results of some studies, but we have to delve more into it. We need to continue to offer choices of vaccines for use in our program and continue to increase the public education. We've recently got a small grant from UNICEF, and we will be launching that grant, the proceeds of that grant on Saturday. Where we're using the mobile buses. They've helped us to signage them, get some bumper stickers, get to DJ, get some music going, to try and target especially the younger people. when we looked at our profile of who had been having vaccines, we realized we were targeting more the older people. But the bell curve is such that we need to get hold of these people now between 12 and 40. Not that we're going to specifically say that, but we need to target some of them. So we thought that by that, the music that goes towards their age groups would be one of the ways we want to get some influence people who, you know, who can come forward and endorse the vaccine and take it. And we're using the mobile buses to take the services to the people. We've been under the trees, the resource centers, malls, and we're continuing to do that. And we're actually even expanding it in that we're getting some mobile teams out of the clinics to actually go to the resource centers and community centers and try to encourage the people around to come, because it's much easier for them to just come out their house and go to the community center than to catch a bus, bring 2 and 3 children along with them to go and get their vaccine. So we're trying to take the service to the people at the grassroots level, but it's hard planning because of our shortage of staff, but we're trying. And in the next week or 2, you will see more sites, more community sites being available for people. We will still have 2 or 3 of the regular sites like the number 2 building, the Masonic Lodge, and I think we're doing Mile and a Quarter and the Christchurch Parish Church Hall. And one of the things that we look at, we've looked at our incentives for people to come forward. They've used that in many countries. But right now, personally, I'm not in favor of it, because I think that we should feel that this is a civic duty. It is a duty that we as individuals should take our vaccine to protect our family, to protect us first, plus protect the family, our neighbors and our co-workers, and our country. So personally, I'm not in favor of giving people house and land and whatever else. So, but it's something that we might have to consider later on if we can't reach that 5 or 10% of people. But at this time, I'm not in favor of that. And so that's the end of what I had to say. I mean, we'll talk about other things as we go along. Thank you.
Thank you so much, Dr. Ferdinand. We can see you're doing quite a bit of work with your vaccine campaign. We go straight now to Ms. Redmond, and Ms. Redmond will share her perspective on vaccine and education.
Good night and thank you. The doctors have given the medical perspective, and of course, my perspective is coming from the position of education. And we have heard, we know that vaccines are very important in attempting to effect a return to some measure of normalcy in our society. Objective analysis of what is happening globally in relation to COVID infection rates, if we compare countries with high rates of vaccination and those without, then the comparison bears out the fact that vaccines are important in controlling infection, illness, and death. In terms of the impacts on education, it has largely meant an emergency education response. That emergency education response has been online instruction or a hybrid situation of combined online and face-to-face instruction. I have constantly repeated that despite the best efforts of teachers, of students, of parents, that the inherent inefficiencies of online instruction, especially at the level of the school, give rise to serious teaching and learning deficits. That is indisputable. COVID too has affected the effective assessment of students in our system. It has affected 11+, and even more so on our exit exams that the older students do at CSEC and CAPE level, where approaches by those examining bodies who have the responsibility for certification of our students at that level, where their approaches in terms of the structure, in terms of the timing, in terms of the content of the examinations in 2020 and 2021 have essentially not adequately responded to the challenges and realities of education in a pandemic. They have not. The reality of the hundreds, I understand it is over 130 under 18 affected children between the 1st of September and today. I hope that my figures are correct. The doctors can confirm or otherwise that number. They must be addressed. And vaccines are our most efficient course of action in this regard. The potential impact of continued online instruction with its inefficiencies and deficits cannot augur well, either for the immediate or the long-term future of education for our students generally, and for those who go on to seek further education and training at higher levels. We are going to suffer serious deficits in terms of the needs that must be met for the economic and the economy and development of our society. The most effective way for students to get back into a safe, productive school environment, especially in our context of community spread of the Delta variant, is with vaccines. Vaccines will play a vital part of the layered protection of individuals within the school environment and within the wider society. Now, I do intend to look more in depth at the impacts of COVID on learning in terms of problems with the students have faced and the problems the teachers have faced, but I hope to deal with them through the questions that I am assuming that we will get, and the impediments and implications of online instruction, continued online instruction for an extended period of time, something that can be effectively managed and done away with if the correct numbers, that critical mass of 12 to 18-year-olds are vaccinated. And I will end my introductory remarks here and await questions when I can go into the other aspects of my presentation.
Thank you very much, Ms. Redmond. So we have heard from Dr. Cave on the effects of the COVID-19, especially Delta variant on children. We have heard from Dr. Ferdinand on the campaign to vaccinate our young people. And Ms. Redmond has spoken about the effects, should I say, on education in Barbados resulting from the spread of the COVID virus. Now we entertain your questions. We note there's a little delay between the streaming and those online are still listening to Ms. Redmond, but we continue with the questions. And to ask the questions, Line Jennifer will pose the questions. She would have been given the questions via the chat. Line Jennifer, have you received any questions as yet?
Yes, I have a question from the viewing audience. And my first question is, how can we trust just a year of research? And what research has been done on children to date? Long-term effects? And what is the variant rate of recovery of children vaccinated versus unvaccinated? And it's for the doctors. The person did not specify which doctor, so.
Well, let me have a go at answering that. There's so many aspects to that question. And from the way the questions are asked, I detect a strong strain of skepticism. There are some assumptions there that I think are not correct. Vaccine technology has been in development for a long time. This is SARS-2. From SARS-1, when we realized how difficult a problem that would be, the research into how do we combat it started. So when the opportunity came to customize it to this SARS-CoV-2, we were already well on the way. So it wasn't that in March of last year, the scientific community suddenly discovered, oh, here's a problem, we have to start from scratch. Oh, maybe there's a vaccine. Let me Google and see how you make a vaccine. What is step 1, step 2? You know, the way we are able every year to get out a new flu vaccine is dependent on existing research and technology that is tailored to new viruses as they emerge. Now, the effects on children, specific questions like you are asking, I don't know the answer specifically to numbers as to how many children will get COVID seriously. We know that it is relatively rare compared to how many children will get COVID. We know that the kind of variant matters. We have only been vaccinating, as you point out, children in a shorter period of time than adults. So the numbers are not fully in. Yes, this is an issue that involves some faith and some trust. A healthy dose of skepticism at looking at what is being offered, why and by whom. I think that is important. But I think it would be remiss of me to say that waiting and let's see is a good option. I know traditionally that has been regarded as a Barbadian trait, as cautious people. You know, in Trinidad, anything that is new, they're the first in line, and then it passes. Other islands have distinctive personalities. Jamaicans are going to be extremely skeptical, maybe even paranoid that this is something being done to them. Barbados has always been intellectual in our assessments, but also cautious in our approach. The problem right now is the virus is not cautious. So while we wait, that is in effect a decision to give the virus the upper hand. Maybe Lion Jennifer, you can remind me if I've missed any aspects of the question.
No, I don't think so. I think that was thoroughly answered. Thank you, Dr. Cave. There's a question too.
Let's
Lion
go right
Lloyd.
ahead.
Lion Lloyd, are you ready for question 2?
Yes, I am. Can you hear me?
Yes, we
Yes.
Okay, now this question is being asked of either of the doctors, and I'll start with the end of the question. The end of the question says, please, no anecdotes. Now the question is, how effective will the present vaccine be against evolving variants? And the person wants numbers, facts, and figures. Thank you.
Well, I will pass that to Dr. Ferdinand because I do not know the answer to that. When you hold us to a statistical exact number, take experience out of it, take anecdotes, as you call them, which we would call clinical judgment. Yes, we are guided by statistics, but that is not the entire picture. I remember during my training, Sir Maurice Bayer used to tell us that there were liars, there were damn liars, and then there were statisticians. I think you can massage numbers to make any kind of case. I would just caution that right now, the source of those numbers would have to be scrutinized. I am not au fait with an exact number and a percentage to tell you 5% and you say, oh no, it's 7. And I'm sorry if the vast majority of children being mildly affected is not a satisfactory answer. But in order to answer that, we would have to test 100% of children to know, and we haven't done that other in small populations. And then the argument would be that population is not exactly the same as ours. So Dr. Ferdinand, maybe you have an aspect to contribute.
Yes, but certainly I don't have an answer figure-wise. We do know that the virus is changing. We're getting variants, and we have to wait. I mean, it's a waiting game in a sense that a new variant comes along. We need to see what is it doing. Is it having an effect? We have a new variant now called Mu after the Delta. How serious is it going to be? We don't know until it actually starts to act. And then we look and say, gosh, yes, we see that person had Mu and they have gone on to progress to get X, Y, and Z. And, you know, it's a new disease. Every day the scientists are learning new things. So we don't have figures. And as Dr. Cave says, there are some children who are going to be affected, and we don't know if it is going to be my child or your child or whose child it's going to be, but somebody's child who we love, is going to be affected. And when they do, they say, oh, I wish God had given them the vaccine, but it's too late. So, you know, that's all I can say on that point. One other thing, though, I want to carry on in a little answer from what this first question said. A new pizza place opens up. And as Clyde said about the trainees running first, we buy all sorts of things. We go to the $3 store and we buy things made X, Y, and Z and all about the place. And we give them to our children. We eat them ourselves. Do we know really and truly what is in it? And how much of the something that is in it we're eating? This is a little thing, 0.3 of a mil. It's no big set of thing. You take all kind of tablets and all sorts of things that you swallow, and you really don't know what the devil is in it. So, you know, I throw the ball back in your court on that. That's all I can say on that matter.
Dr. Ferdinand, I fear you may want to answer question 3, which
Okay.
is, how many children have experienced the side effects so far from the vaccine?
I cannot give you that answer either. All I do know is that any side effect, I mean, let's put it, any vaccine might give you a side effect, a mild fever, a mild headache. You know, those are mild things that you expect with the vaccine. You give your baby that's only 2 months old, some at birth, we give them the vaccines. I don't see people quarreling and worrying about not giving the children vaccines. They all get a little, I mean, not all, they get a side effect. They get a little fever. They might be cranky and, you know, miserable, off their food or something. So with this new vaccine, we're not expecting anything unusual. Dr. Cave explained that there are some cases that get a mild inflammation of the heart, which usually resolves within a week or two. So, you know, it's expected that you might get a little reaction, but some people don't have any reaction at all. And I certainly have not had any complaints or reports of any serious reaction to the Pfizer that we are using now in children. Maybe I could take, could I expand a little here?
Yes, of course.
Yes, there is a mechanism where any adverse events, we call them adverse events or side effects, as you might say, can be reported. There is a website at the Barbados Drug Service, because they're the ones who are collecting all the information, monitoring it, and referring it to the pool of resources that are at PAHO and WHO. Because this is a new vaccine, because it is not only, I know we're discussing children tonight, but it can be extrapolated to adults. Because it is a new vaccine, extra precautions have been taken to record all adverse events, especially the serious ones, so that the world would know what is going on, because we're not in isolation. We're not a single country here looking at the vaccines. Every country is giving, and every country will have a few cases or some cases of adverse events. So they all go to WHO and they're pooled and looked at. And the whole reason for having an adverse event register is not only to see what this vaccine is causing or could cause or has caused, but it's also to identify as quickly as possible if something has gone wrong in one or two cases, so that we can prevent it from happening elsewhere, other cases. So say, for example, a batch of vaccines come in and we start vaccinating, and we suddenly realize, my goodness, we're getting a lot of abscesses at the site, we're getting swollen arms, you know, whatever. Then we can analyze and say, well, why all of a sudden we've been having the same vaccine but in a different batch, and we haven't had these effects. So why this particular one? And then we go back and find out where was it manufactured, get in touch with we usually go through PAHO, but we would get in touch with the factory, the manufacturers, find out, is there a difference? What has happened? Have you put in something extra? Was there some contamination at the factory or something? That is why you do what we call pharmacovigilance, to find out what is going on with any new drug. Even the regular vaccines that we use, we have pharmacovigilance on them. And, you know, thank God we in Barbados have not had any serious reaction to vaccines in children all the time that I have been the EPI manager. And we thank God for that. But it can happen, and it has happened. And sometimes it's not necessarily the vaccine, it might be our technique. There was a case in one of the countries in Africa where, unfortunately, insulin was administered to the babies instead of the vaccine. The nurse made a mistake, and some children died. And that was what we call personal operator mistake or error. So that's why we have to be so careful when we're giving vaccines. And it's a big responsibility on our shoulders that the nurses and doctors take to make sure that our children are protected, not only from the regular EPI diseases, but now for COVID. So I think I'll stop there.
Next question is for Dr. Cave. Dr. Cave, I think I'll pose this one to you. And the question is, do you think that the current strategies of educating persons are effective? For example, the use of music trucks, DJs, and so on? Or is it time to readjust and seek new strategies? Dr. Cave?
My personal opinion is that there are many different kinds of people and many different strategies work. I'm not sure if you were trying to sell something to me. I would believe anybody shouting it from a music truck. But I have younger friends who find the scientific explanations that would sway me to be dull and boring. And unless somebody who is more current with some excitement is going to say, I do this, so they can say, me too, they're not going to be swayed. So I think it's different approaches for different people, whatever works. I think it's the message, and we're all saying the same thing, even if we say it in different ways.
I was not trying to exclude Dr. Ferdinand from the question, but I realized that you were pretty quiet at the time, so we really wanted to hear you. Thank you very much.
The next question is for Ms. Redmond. The question is, can we agree that even with face-to-face school, there are always deficiencies? Might it be that online is the new normal, and what can be done to adjust quickly and master this online system?
Redmond, you're muted still. Ms. Redmond, if you will unmute your mic.
The first part of the question came as a statement that face-to-face does in itself have deficiencies. Yes, there is no perfect way of teaching any group or individual. Different people learn in different ways, and a good teacher tries to adapt and utilize different methodologies to reach the persons that they're trying to teach as best they can. Now, the online environment in which we are operating, as I said in the beginning, that was an emergency response. And to that extent, you had teachers, students, and parents who were not properly prepared to go straight into that environment. It happened almost overnight. And so the degree of training that those three stakeholders have needed has not always been available, and available to the extent that it has been needed. Teachers have tried very hard and have worked very hard to train themselves to make the online environment as effective as it can be. But there are some inherent difficulties. For example, the digital divide. The reality is that despite the fact that the ministry has distributed close to 20,000, I understand, devices, not every child has a device. Not every child has a device that can work because there's no connectivity in the home. There's no electricity in the home. Not every home is a suitable learning environment. Some households really are not amenable to online instruction. There are a lot of people in and out of the households. There's noise, there are familial disputes. The difficulties of the online platform. Tonight in this program, We have had our difficulties. That is the nature of technology. It is not perfect. And then too, there are the economic and other societal aspects of what a school provides for children. Some children, the school is the safe haven for that child. It is a place where at least one meal is provided. It is a place where some caring and concern and protection during that school day, out of the 24 hours, is provided for that child. So on many levels, the school is a refuge for some students. If we take all of those things into consideration, we can see that the face-to-face mode of instruction is what has worked traditionally, historically best for us. And it is the type of instruction that we need to get back to as quickly as possible so that our children can deal with the deficits that have been created because of how we have been forced to do what we're doing and the circumstances under which we are forced to do it. I hope I have answered the question. I was trying to jot because it was quite long. Have I answered the gist of it?
What can be done to quickly and master this online system?
Okay, well, training, ongoing training for teachers, for students, and for parents who have to assist students, especially the younger students. Another thing is that a lot of people believe that children are technologically savvy. Children can use cell phones, yes. They can go online and go on Facebook and Instagram and use the other platforms. They can send and receive messages. But when it comes to using a platform like the Google Suite, the Google Classroom, many of them are not au fait and as efficient with it as they need to be. So there must be training for them. There must be training for their parents as well to assist them. And there has to be ongoing training for teachers. There must also be, too, access to the best versions of the programs that we use. And that in itself is expensive.
Ms. Redmond, this next question is also for you.
Okay.
The person is asking if the majority of teachers are now vaccinated.
Oh, I can't say that. And I wonder why that was posed to me. I am not a medical person. But I can say that the uptake, as far as I know, by teachers has been good. Definitely so. In terms of the numbers that I heard initially. But I think the doctors might be better placed to answer that question.
In which case, over to them.
Yes.
Not me, I'm a pediatrician. Dr. Ferdinand, your call.
Oh, no. Well, I can go into our system and I can find the exact number of teachers who have been vaccinated in the system. But I can't do it at this moment, okay? Because I'm not technically able to switch and all around. But we can find a number who said they were teachers and who are recorded as having had their vaccine. But a person might have come up and said, oh, and just said, just as a general population and not say they were a teacher. And so we wouldn't have necessarily had recorded them as a teacher. But from my moving around, I thought we had a pretty good uptake from the teachers, especially on our second go round.
I can say that I am fully vaccinated and have been since the beginning of March. All of the officers in the BSTU are fully vaccinated.
Dr. Ferdinand, I think you better remain for this question. if those children under 12 cannot be vaccinated and MU can possibly evade the vaccine, what would you say to those who are still hesitant about vaccinating their children?
Okay, so we're talking about vaccinating the children between 12 and 18.
Yeah.
And I'm saying they need to go forward and vaccinate because we cannot assume that the mu is going to give problems. It might or it might not. And it is always better to be safe than sorry. Now, this is how I look at it. In a family, you're going to have maybe some children who are under 12 and some children who are over 12. And if we know that the younger ones cannot be vaccinated at this particular point in time, we need therefore to protect them. And the only way to protect them is by us, the older people and the older children getting vaccinated. Children learn. I mean, I have a little 8-year-old grand, and I know she's very astute when it comes to wearing her mask and what's up. But children are like us humans, we are social individuals. We like to hug and play and touch. And so they're going to be more vulnerable to getting the disease. And so the more of us who are vaccinated, the better for them. So for us to protect those younger ones who at this time cannot be vaccinated, we need to, yes, we need to teach them about social distancing and try to get them into the habit of doing it. And they do learn quickly, but there's always that unguarded moment that they might have. And we should do the right thing, get ourselves vaccinated and all those in our family who are eligible to be vaccinated.
And Lloyd, I think you better take that
Question?
next. Yes, because it's a long one.
Yes, it is a long
It's a long question.
It starts off with some letters for which I do
Yeah,
not.
which I have no clue what those are.
JCVI. I don't know what that means. Anyway, they say UK did not want to vaccinate children because for every million children getting the first dose, you prevent just 2 ICU admissions, but you risk 17 cases of myocarditis, which can kill 20% of the patients after 1 year. So please confirm why you think that risking 17 cases of myocarditis to save 2 ICUs is worth the risk. It's long, and I hope you don't ask me to repeat the question.
Let me try and answer that because, and I'm not going to quote Samaras Bayer again about the use of statistics, other than to say those statistics seem to be, to me, to be from a questionable source because we do not know that over a year, whatever percentage of children with myocarditis are going to progress as stated, because it hasn't been described for a year. What we do know is that the majority of them resolve, so they're not going to progress to death. So I think that is a jumble of false information, maybe selected from various sites. The early risk for vaccination in the UK was predicated on when children did not seem to be affected. That was a different variant. So that is a fruit salad of various bits of information. And I, number one, don't believe it. But number two, don't want to respond to something that has been cherry-picked.
Well, let's move to the next question. And I believe it is for Ms. Redmond. And it says, how will children with learning deficiencies be addressed on this let's read it again. How will children with learning deficiency be addressed in this online environment?
Well, first of all, if there are children who have learning deficiencies, then there are specialist teachers who will address the needs of those children through assessment, identification of the deficits, and methodologies to address the deficits. Now, the deficits that have been caused because of online instruction and the limitations of online instruction, all that teachers can do is to apply some of the same methods, attempt to determine, for example, at the beginning of this school year, where the children are at through assessment. And I know in some schools, and the ministry is also following that methodology and have indicated that the schools should, we will have to adjust syllabi, especially in the lower schools. We can't do it in relation to CXC, but in the lower schools, we can adjust syllabi to meet the children where they're at once we identify those deficiencies. And we have to try as best we can in the limited day, school day, because another aspect of online instruction is that it is not the normal length of the school day. You know, we have a reduced school day because of the exposure on screen time that children have and should be limited to on a daily basis. So our school day is cut short. As a matter of fact, just as a matter of interest, I was working out how much teaching time you lose and with online instruction. And it works out to, for example, most CXC classes, subjects, have 4 classes of that particular subject. So for geography, you have 4 classes of geography per week. And those are 4 40-minute classes. With online instruction, your classes are limited to either 25 or 30 minutes. If it is 30 minutes in the upper school, for every week, you're losing 1 full class of 40 minutes that you would have had at face-to-face. If you have a 12-week term, those are 12 classes potentially, teaching classes in geography that I would be losing. And for the school year, 38 weeks, potentially 38 classes where you have a CXC or CAPE syllabus to complete to properly prepare students for the exams. So that was an aside, just for persons to understand the difficulties. But in relation to, and that again, the time factor is a deficit in itself. And that is a deficit that we have no control over. But in terms of the other deficits, yes, we try to identify those deficits and meet the children where they're at as best we can. We do that either through, and often teachers still engage in extra classes in their own time with students. And in the lower school, we have been looking at reducing syllabus content so that you teach what is deemed as, at this point in time, essential.
That, I think, was the last question from the viewing public.
Okay, well, thank you so much, Jenny and Lloyd, for those questions. And I think it's a fitting time for us to wrap up our presentation here. And it is my pleasant task, ladies and gentlemen, to first express our gratitude. And when I say our gratitude, the gratitude of the Lions Club of Barbados East to our panelists. And I want to start by thanking Ms. Redmond, who came in at the very last minute and did a splendid job in defending her views on education and to share her perspective on how we can learn from this virus and the impact it has on our children. I know Ms. Redmond has always been very passionate about teaching, and I am proud to say that I'm a former student of Ms. Redmond, way back at the law school in the early 80s, right? So Ms. Redmond, thank you so much, and we look forward to even greater partnership with you.
You're most welcome.
Dr. Cave and Dr. Ferdinand, I can't express enough our thanks to both of you for having taken the time from your very, very busy schedules to spend time with us and share your perspective on the virus and on the campaign. I note that when we called you, both of you were very eager and willingly accepted to be a part of this event. And we thank you tremendously. We want to congratulate you on the splendid work you have been doing, Dr. Cave, with our children, and Dr. Ferdinand with the vaccine. We congratulate you on it, and we express our gratitude to you. Thank you so much.
Thank you very much.
And we look forward to working with you on other projects in the future. Our gratitude must also be extended to our participants. We have had a maximum of 104 persons viewing our YouTube video. So your advice, Dr. Cave and Dr. Ferdinand, and your comments, Ms. Redmond, have gone far. And we hope that they have been impactful and that we see less hesitancy and more persons coming forward with their children to be vaccinated. Again, we want to thank our IT coordinator. We know we have had some challenges with IT, but as Ms. Redmond said, with IT, we always have challenges. So Lion Wendy, we thank you so much. Lion Jennifer, Lion Lloyd, and all the Lions who have been working behind the scenes, and Lion President, we express our gratitude to you. And thank you, stay safe, and we look forward to working with all of you again. Thank you so much.
Thank you very much. Good night.
Good night.
Good night.
Good night all, and be safe.